There has been a lot of discussion, and it's renewed now, about what to do about the costs of the medical system. I would love to throw it to you, Nick, to first talk about some of the underlying factors for why healthcare is so expensive.
Well, let me back you up and say, in around 2005 to 2011, I had built primary care clinics trying to perfect this impossible problem of what better care looks like. We set out to take better care of people and to find out if there was a business model in doing so, which we found out that there was. And fundamentally, it was the difference in being proactive to taking care of people versus reactive, waiting for the patients to express their needs. So about that time, the Affordable Care Act came out, and kind of became a student of the literature and realized that it was really about upside incentives for practices to do more, but had very little quote unquote motivating factors to engage practices to make them change. It was just kind of cherry picking the practices that saw the opportunity. Well, fast forward to 2017 when macro legislation got released, it came with much stiffer downside penalties for practices and non-performance. And when you kind of combine what the government's doing from a legislative perspective and the industry problems of as quote unquote Obamacare or the ACA came out and insured 10,000 or issued 10 million, new insurance cards, and then you've got the baby boomers retiring, the oldest, sickest, highest risk, highest cost patient population, and they're printing about 10,000 of those new insurance cards a day, and a trend that's expected to continue for the next 13 to 15 years. Healthcare costs expected to double over the next 8 years. All of these things put together, it's an overwhelming problem for our country. And as we looked at it, we saw the only real solution is taking better care of people. Healthier outcomes equal lower overall costs. So that's kind of where we set out to be more proactive and help practices and providers be more proactive in managing their patients as opposed to reactively treating the patients.
So, Nick Smith, you've very closely examined these issues. What are some of the underlying factors, different things going on at hospitals and with general practitioners that are making costs so high for them and then therefore gets passed on to consumers and to the government? One of these big categories of an issue I'd love for you to talk about is the notion of catastrophic hospital visits, because this seems to be something that is really undergirding a lot of what we're talking about.
Absolutely. So as we look at, catastrophic claims, we define those algorithmically by any episode of $50,000 or more in a 10-day period. So as we data mine, we're looking at, an ambulance ride, an ER encounter, a hospitalization, a procedure, post-discharge care, 10 days of service that equate to $50,000 or more. And as we data mine those and look at the causes of those, you're looking at, a lot of cardiovascular encounters, a lot of diabetic complications. We find it to be much more around chronic diseases that are mismanaged or perhaps not managed, as opposed to, the unavoidable things, what we call the silver bullets, the person in a critical burn unit because of a house fire or a car accident. We find much more what we would define as somewhat avoidable with proactive patient care as opposed to the unavoidable activities.
And we'll delve into that and how you're addressing these issues. But Dr. Randy Tobler, I want to ask you to lay the scene from your perspective and tell us a little bit about the nature of what's going on in hospitals today that is really helping to keep costs so high that need to be addressed.
Whether it's at the individual level, Jimmy, at the hospital level, at the mom-and-pop doctor's office level, or at the federal government level, we know that especially over the last 20 to 30 years, what has been driving misery with premature chronic diseases, and Nick mentioned it, cardiovascular disease, diabetic problems, and their complications, heart attacks, strokes, and all of the things that ripple off from those chronic diseases. We've seen just a logarithmic and exponential increase in those diseases. diseases. And especially in some of the impoverished areas, and I know that, in and around the Denver area, a lot of the community health centers, just like in my area of northeast remote Missouri, we are seeing just an explosion of these chronic diseases in younger and younger people. And we know that at the same time, the healthcare costs of the nation are largely borne on the shoulders of chronic premature diseases that, if not managed well, or better yet, prevented in the first place, result in the high-cost centers of care, meaning the emergency room and then admission to the hospital with these extraordinarily high costs. And that translates to, out-of-pocket expenses that are just skyrocketing for folks who are on or underinsured with higher deductibles and copays. And, of course, that burden that is to the taxpayer in terms of Medicare and Medicaid, we all know the headlines there in terms of the explosion there. So the linchpin, the key to getting a handle on this, both for the patient's welfare and medical benefits so that they can live a long and healthy life. And as I like to say, we call it the rectangularization of the life curve, right? Rather than us starting to get more pills and more hospital visits and more tests when we're 40s and 50s and gradually like a glider coming to a landing, we'd like to be a rectangular curve to where you're running triathlons and out in the fly fishing and the stream and on the ski slopes till you're 80 or 90 or 95 and you drop dead. I mean, that would be everyone's wish, right? Well, by partnering with Nick as we try to navigate this system, we are able to look at these risk factors that accrue to people, whether it's a family history, a personal lifestyle risk, or both, and then we can get on top of it earlier so that we're not spending oodles of money trying to salvage people's health. Rather, it's better to prevent it.
And Dr. Tobler, when it comes to this notion of, I would guess you might phrase it as preventative care, one of the best ways to really go about this from a physician's perspective that maybe a lot of folks are in the medical community aren't paying attention to or focusing on as much.
The thing is to be able to spend a little time with an individual, and many of the things that the federal government has imposed on some of the Medicare and Medicaid rules, as well as then they flow down through the insurance companies, which tend to follow the government's lead, has resulted in the past in a sort of a volume business. A patient gets sick and they come in and you treat them, and then it's a short episode of care and they're out the door. It becomes a revolving door for folks. But if we can spend a little time and spend 20, 30 minutes talking to them, discussing with them in detail their family history, their personal history, their lifestyle, and if they've developed an early case of prediabetes or borderline hypertension, if we can address both the lifestyle issues and then the medical issues in terms of medications and other things that can be done in an ambulatory setting, that reduces the cost. It reduces the time off work. It reduces the cost both to the patient and to the facility and to the system. And so it's that ability to identify people that are either at risk or in the earlier phases of the disease process and get a hold of it before it gets out of hand. And then it becomes, as I said, a salvage maneuver, which is expensive and inconvenient.